আচ্ছা ঠিক আছে
ম্যাডাম আমরা কি শুরু করব ম্যাডাম?
হ্যাঁ শুরু করো প্লিজ।
শুরু করো।
Respected ophthalmologist, welcome to International Society of Manual Small Incision Cataract Surgeons Bangladesh Chapter webinar. Professor Abha Hussain, the chairperson of ISMSICS Bangladesh Chapter and President-elect of Asia Pacific Academy of Ophthalmology, will start the webinar with welcome address. Professor Abha, madam.
Thank you so much, Dr. Ashraf. It is a great pleasure and honor for me to introduce all the dignitaries of ISMICS. Our chief guest is Honorable Dr. Debashish. Will you please share the screen, Dr. Ashraf?
Yes.
Please make it bigger. Individually, yes, right. Dr. Debashish Bhattacharya. His name is so popular in Bangladesh as because he is just like one of our family member. He has come to Bangladesh so many times and he is very good friend of Bangladesh. He is the president of ISMSICS. He was the former president of AIOS. And he is the founder chairman of Disha Eye Hospital, West Bengal. I can remember that I was there in with Professor Said Mudassir Ali and all other dignitaries to visit Disha Eye Hospital, and their hospitality still now we can remember. So thank you, Dr. Debashish, to accept our invitation and be the chief guest of this webinar. Dr. Amulya Sahu, the name, very famous name, and he is the founder chairman of ISMSICS, as because he is the person for whom we are having this ISMSICS. Founder chairman, Sahu Eye Hospital, Mumbai, and he is also the keynote speaker. And the 2 millimeter incision, really exciting. And I have request Professor Mijan to request you to just present this presentation. Thank you so much for your. Dr. Jagannath Boromani is the executive chairman of ISMSICS. And these 3 persons, when we were last visited, not visited, but attend the conference of ISMSICS, their hospitality is so much. We were so happy to be in the Kolkata and there remain for some time and visited also to some places as they have arranged all these things. Professor Mohammad Sharfuddin Ahmed, he is the special guest of this webinar. He is the president of Ophthalmological Society of Bangladesh, advisor ISMSICS Bangladesh chapter, but very important person for Bangladesh as because he is also the council member of Asia Pacific Academy of Ophthalmology. He is the regional secretary of Asia Pacific Academy of Ophthalmology, and he is always with us. Thank you, Professor Sharfuddin, to accept the invitation to be the special guest and also the panelist.
Thank you.
The main person, actually, he should be here, not me, but he is so kind enough that Professor Mizanur Rahman, he is the president ISMSICS Bangladesh chapter, but he make me the chairperson. I think the president should be the chairperson, but as he is my student, he respect me, he love me so much. He always tell me, Madam, you will be the chairperson of this webinar. So I am here. And he is also the president of Glaucoma Society, Bangladesh Glaucoma Society. Professor Hoshem Jiada, so glad to see you. He is the president of ISMSICS Egypt chapter. really happy as because you are here with us. Next, Professor Hassan Shohid Sohrawardy is the panelist. He is the President-elect Bangladesh Glaucoma Society. He is very well-wisher. He is very guardian-like personality in Bangladesh. Everywhere he present with us. Professor Mohammad Abdul Kader, the dynamic person, Secretary General of Ophthalmological Society of Bangladesh, the heart of the society. So he is always very helpful for all the ophthalmologists of Bangladesh. Professor Shakotara Shakur Mili, see the lovely face and the smiling in the photo, and also living Mili. She is the professor of National Institute of Ophthalmology. She is an oculoplastic surgeon and also ocular oncology, and she is very familiar to our society, to our ophthalmology family. Dr. Purobi Rani Devnath. She is the speaker, very great leader also. And she is the associate professor of Barden General Hospital, but she is very much involved in Bangladesh Medical Association, a great leader. Thank you, Purobi. Dr. Sams Mohammad Noman, senior consultant and head of Glaucoma CEITC. Just a few days back, he make an interview in Bangabandhu Sheikh Mujib Medical University and got the appointment letter as associate professor of glaucoma. So he will be in Dhaka very soon, not in Chittagong, and he is also very dynamic person. Dr. Ashraful Haq Hridoy, today's master ceremony and also speaker, moderator, treasurer. No, I didn't finish. Treasurer ISMSICS Bangladesh chapter, and he is also the president of Bangladesh Young Ophthalmology Society. Dr. Mohammad Mustaq Ahmed, General Secretary ISMSICS Bangladesh chapter, and he is very much involved in our Ophthalmological Society Bangladesh, as because he is the member secretary of scientific session. Very nice person. So I have introduced all the guests, all the panelists, and all the speakers. I think the moderator should start, and we'll be in the original scientific session. Thank you, Ashraf, and thank you, Mustaq. Please.
Thank you, madam. Good evening. Now I would like to invite today's keynote speaker, Dr. Amulya Sahu, founder chairman of ISMSICS. He will talk on 2mm MSICS, why and how. Dr. Amulya Sahu, sir, please.
Am I?
Yes, sir.
I've shared the screen. having some problem. Anybody there to help?
Asif.
I shared the screen, but it is not showing there.
On the desktop, I could see Bangladesh PPT. You better click that. You can close this email.
Hello, Professor Amonu.
Close this email.
Okay.
Dr. Sahu sir, you are going to your email address. Please close it and go to your desktop, please, sir.
Dr. Ashraf, how are you?
Yeah, Professor Hussain, how are you, sir? Thank you for joining.
I'm fine. Sorry for being late.
Close this one,
Internet is unstable here.
Yes, sir.
But I'm with you.
I'm having a problem.
Hello, Dr. Hussain.
Hello. Hello.
Hello, Dr.
Yeah.
James, my friend.
Click the
how are you?
Bangladesh
Dr.
PPT.
Abba. Professor
Yes,
Abba
double
Hussain,
click.
how are you? How are you, sir?
Okay. Okay, fine. Hosam Jaidi, good evening. Professor
Good
Saifuddin.
evening, sir. Good evening, sir. It's my pleasure to be with you today.
Thank you. Okay, we can hear from Mullu Shah.
Make it screen. Click F5.
Yes.
Go down. There is a cup-like figure. Click that. It will become down. Also, there is a cup-like figure.
This one?
Sir, at the down.
No. Go down. Completely down.
Okay.
So completely down at the
and go
right
to the
hand,
right
there is
side.
63% written there. And just before that, there is a screen-like feature. Just click over it.
One?
Yeah. No.
Not this one?
No. Close that one.
Like,
Correct. Go down and to the right. Yeah. Go more to the right side.
yeah, this one?
No, sir. More to the
No,
right
go
side.
to
There
right
is
side.
63% written there at the right side. More right, sir. More right. Just up.
Right,
Yes,
right.
yes, sir. Yes, sir.
Correct.
Yes.
Correct.
Thank you,
Click
sir.
that.
Okay. Thank you so much sorry for the inconvenience. I'm not very conversant. See, thank you very much, Abha Hussain, Professor, and all of you for giving me this opportunity to share my experience with 2mm MSICS. As you know that now the world is world over, MSICS is creating history, and we have opened more than 12 centers abroad, and now the Brazil is opening a center. So all of you will be part of the MSICS journey to the future. Now, as you know, the FECO emulsification has been the gold standard for more than a decade now. But the MSICS is now creating a space for itself, and the future of cataract surgery will be more balanced. It will not be any more driven by the commercial interest alone. Because before the FECO, there have been wonderful surgeons, unique surgeons were there. They have given a lot to us. And after this FECO has, as you know, that it has reached this peak. Now the SICS, the art of cataract surgery, is going to rise. As you know that in India we have now 3 or 4 innovative things are happening. I am doing 2mm. Boramani is doing modulation, astigmatic free cataract surgery. Rajiv Raut is bringing the software guided MSICS, and now he is going to launch the robotic MSICS in the World Conference in Chandigarh. So there is a lot is happening, and I see that there are a lot of talent in Bangladesh, and they should take up the research part also. We have now formed a research and committee. So similarly, Bangladesh should also see that the young people get into research of MSICS. Now, few things I think had to change now. We have been talking about MSICS. 6mm incision cannot be a small incision. So what I want to propose now, that we should call it a scleral incision cataract surgery. manual scleral incision cataract surgery, not small incision, because the small incision has to be either 2 or 3 millimeter incision. That should be known as a small incision cataract surgery. Now, as soon as you say 2 or 3 millimeter, a lot of people have a problem in imagining how it should be done, and there will be a lot of corneal edema and all the things. So now you see that factors contributing to less astigmatism, as you know, small incision, steep axis incision, crown incision, and more distance from the limbus, then we have less cauterizations. So these are the few points which contribute that, and then the proper apposition of the incision site, that gives you less interest. Before we go for the incision, we must have a little idea about the limbal arrangements there. The first thing to end is the Bowman's membrane, that is a before, and the mid limbal line is the Desmond's membrane. This ends there, and then we have the scleral spur. There is the superior side has got a more thickness of the limbus than the compared to the lower side, and the side has still less limbus. This understanding should be there when we are designing the wound. Otherwise, we can create problem for ourselves. Now, these are the common things all of you know. Then we, by experience, we have come to know that the crown incision contributes least compared to others, less astigmatism. Many people don't do a side port, but I do 2 side ports at 10 o'clock and 2 o'clock, because that gives me more position for maneuvering my Simcoe cannula, and to take out the subincisional cortex. It becomes easier because I can do that with my left and right hand. But directly, when you are doing a bigger incision, you are going through the main port. The possibility of iris prolapse is there, and possibility of touching the endothelium is there. And it is if you are a beginner, there is a lot of problem, and you can create damage the posterior capsule also. That fear is there. So side port, for that we have to. I advise that we should not go for a flat knife. I use the MBR knife for that, because in that case the wound designing becomes much better. Now, if I'm going for a very small incision, there is no need to cut the conjunctiva too much. 4.5 millimeter conjunctiva cutting, and I separate the conjunctiva and tenon separately, because in that case, when you are closing the wound, there is a infection chances are less, gram positive, gram negative, all these things are taken care of. I leave a 1 millimeter frill of conjunctiva so that I can oppose it much better. I usually give the incision is mostly 1.5 millimeter behind the limbus, and I give a 1 millimeter back cut. Sometimes it is 1.5 millimeter also, because it gives me a lot of space for creating a side for the pocket. And even if I have done a 2 millimeter incision, which I define it by closing it between the two back cut lines, but I have got the advantage of going through the pocket and creating the tunnel. Now, as you know, this is a 3 planar incision. Many people advise that you take a 11 number knife or 15 number knife and cut into it. But there is a problem in that case. Many beginners, they can just go through and create a problem. So it should not be totally vertical. It has to be slightly slanting, because it helps the position better. So 3 planar, it is a self-sealing thing. So okay, so anyway, this is a animated. Those who are beginner, they can understand it better, but those who are doing it, for them it's not to be, there is nothing much. Now here, when you are doing this, you have to go both sides and then extend to the periphery. Earlier it was advised you go totally to the periphery, there is no need to go totally periphery. If you are injecting the lens, you may not go to the periphery, you can keep it square also, still it will be a good thing. Now these are the modification of the instruments which I have done, and they are very simple, and all of you can do that if you try. Now earlier what I have seen, we have a jet cannula, we have a cannula which goes and injects to us and touches the zonules many a time. So what I have done, in the front I have closed, and in the above I have made it an opening so that the jet comes out. When you take it below the rexis and inject it, the fluid goes and hits the back of the rexis, and the fluid flows like a flowering thing, and separation becomes much better, and without traumatizing anything else. So this is a thing which will help you. And now this is a multiple jet cannula. What happens now, most of the time when after the operation is over, a lot of debris get deposited. Many a time we can't see the the angle what is lying there. With the jet cannula you can flush them out. If with a single jet cannula, if that is debris is there below the endothelium, if you flush it slowly, that they fall like a flowers there, so you can see it better. So, and this is many of you have been using this Simcoe cannula, this cannula, viscoelastic cannula. You know it is a rounded cannula. But if you are making a side port, which I do a rexis from the side port, if the side port is square and you are pushing the round thing there, there is a lot of chances of creating desperate separation. So what I have done, that you compress the tip of the cannula and make it a square. So a square goes inside the square. So, and that helps. And plus I get the advantage when I'm breaking the lens, and I keep this cannula above the lens and go on injecting the lens and break the lens and take it out. So in that case, if it is round, there is more chances of touching the endothelium. That fear is gone there. Now this is a modified here. This one is a I'm doing it under topical anesthesia, separating the conjunctiva, leaving the field there. The cauterization should be erasing. You don't use the ballpoint country, because in that case you can scar the sclera. The surgery is very artistic, and you can enjoy. Once you practice this, you will enjoy. This is a modified dialer. I just pull the rexis towards myself and then nudge the lens. And this is breaking in the tunnel. you can put that lens directly without any problem, because you have the advantage of the pocket there. Here I am showing you I'm breaking the lens. The viscoelastic cannula is going over the lens, and I break it to 2 pieces. You can break it to 3 or 4 pieces as you want. So this is a tunnel breaking. I'm just putting a multifocal IOL there. The multifocal IOL I did 2 days before. That lady had done one eye, and after 7 days she came back for the second eye. This is a toric lens. So you can inject it, or you can take the advantage of the pocket and so because I am doing it, naturally question will be there, what result and how whether there is good or not. So we took out a pilot study for that, and we try to study the astigmatism. I have the uh, specular microscope, Conan specular microscope. I have only for this purpose. So I will share some few cases with you, and all the routine procedures we have followed, including consent taking and exclusion criteria, inclusion criteria. All of you know, so I don't want to get into details. For that, I will just share some pictures of the first day post-operative. Now, this case, I keep a air bubble, so as you saw that the first day post-operative cornea, and the steep axis was 10, and the vision next day was 6 partial. Actually, 2019, I did give a live demonstration in All India Institute and in Udaipur. So next day vision was 6.9 there. In 2005, I did a live demonstration at Bombay, 3 millimeter. So that, and after so many years, I give a 2 millimeter incision. And you saw the endothelium loss is not that much. The cylinder, which was 1.15, and it reduced to 1.7. Same thing, the vision is 6.9. Now you is 2,700, and it's quite less. So you see that you can see the either I'm not whatever I'm observing, either I'm not contributing or reducing at least 0.75 to 1 cylinder in the giving the incision in the steep axis. So we are maintaining a very good record of all cases, because I am questioning myself where if anything is going wrong. So because that will give me chance to improve myself. You can see.
Okay.
Okay. Cylinder is.
Hello.
Hello.
जी sound.
Okay.
जी अच्छा चलो.
So as you see that the average is quite less in the end of the 1 to month. We started with astigmatism average of 0.62, it became to 0.04. So you can see it is quite less astigmatism. So mean reduction is hardly significant. So what we started, we had post-operative first wave edema in 37 cases, and then it becomes, after 1 month, it becomes 61 of them. Out of the 65 cases, 61 of them had wonderful cornea. So this is I'm sharing with you so that you have the gain the confidence to try out, but don't immediately go for 2 millimeter. If you are doing a 6 millimeter, gradually go on reducing and modifying your instrument to suit your purpose. And so this is a technique all of you can master, and the more people practice it, the more data will come, then we can share it with the world. 2 millimeter is an extremely effective technique. Challenge lies in the delivering the nucleus from the small incision. If mastered, can be done with extremely good results. So I would like to interact with you all of you. Thank you so much.
Thank you, sir. Thank you for your excellent presentation. We have learned enough from your nice presentation. Uh, Now I invite Dr. Devashish Bhattacharya, today's chief guest, President ISMSICS, founder chairman of Dishai Hospitals, West Bengal. He will talk on SICS in supra-hard cataracts. Dr. Devashish Bhattacharya, please, sir.
Dada, you are scaring all of us.
Yeah. I've shared my screen. Can you see it?
Yes, sir.
Why are you scaring us?
Suprahard cataracts often, is a kind of a nightmare for most of us, and that's what I will be talking about. So essentially, what it means is we have an 11 millimeter cornea, but in a suprahard cataract, we have huge nucleus, which can be almost even 9 millimeters, which can actually leave very little space in the eye. And so this is the 9 millimeter thickness. And so essentially, my previous speaker, Sauser, told you about the 2.5 millimeter or 2 millimeter incision. But what we should concentrate as to how to get these kind of hard nucleuses outside the eye. And we must also remember that the moment we go beyond the limbus, the corneal flap valve action and the water tightness of the wound is lost. So essentially, we have to plan an incision with a huge scleral pocket to accommodate not only the width and the hardness, but also the thickness of the nucleus. And so it has to be a relatively big incision unless we are bisecting or trisecting the nucleus. And then only we can bring this nucleus out. So, and essentially we must also remember that many of these cases will have poor pupillary dilatation. We may have to use Irish hooks, and some of the cases will have pseudo exfoliation or zonular weakness, and the bag will be full the anterior chamber may be shallow, the endothelium may be compromised because most of them are elderlies. So we have to take this whole gamut into consideration, and therefore, SICS becomes a very safe option for a pristine clear cornea the next day with the SICS. So as I was telling you, these kind of cataracts, the cataract is not only wide, but it is also thick. So all that, it will be 5 millimeters thick. So all that has to come out through the incision. So we have to design our incision in that way. So let us observe this surgery where we are actually taking the corneal valve down to 3 and 9 o'clock, because that is what gives us the the maximum internal incision, because we need a very big internal incision for engaging the nucleus in the sclerocorneal tunnel. And we need to have the pockets, and the pockets also to accommodate the thickness of the nucleus. So, and all this has to be in one plane. We cannot have multiple planes. So this is to show you the extent of the tunnel. And while we go in and give the internal incision, it has to be parallel, because we have to carry the incision to the 3 and 9 o'clock areas. So, when we go to the 3 and 9 o'clock, it has to go, the keratome has to go centripetally, and every time we end, we should cut when we enter and not cut when we leave out. So, and then we must do a very big rhexis, and obviously when we are, we have to do a big rhexis because the nucleus is very big, and there should not be any nuclear size disproportion to the, and here when we are bringing out the nucleus, we have to just dip the posterior lip of the incision so that we can deliver the nucleus properly. And at the end of it, we can well appreciate that we have to have a solid, stable chamber which doesn't leak. So I'll now run through another, because I'm focusing on the incision. It is very important for us to get the incision right, because again, these kind of cataracts are not uncommon, and especially in this COVID situation, we are getting more of them. So it is a very simple surgery which can actually give excellent results. This is an envelope capsulotomy, because sometimes, it becomes problematic for, and this is so quick. You can really do it in no time. And so essentially the nucleus, you need to just take it out of, but the anterior capsule from the capsular envelope, and just by posterior lip depression, you can take out the nucleus, and you have the anterior capsular tag, which you can just tear it off. And here, we are just holding the capsule with the Simcoe and just taking it off. So that finishes the surgery, and you just implant the lens. So the third way of doing it is to actually fracture the nucleus, in which you use a snare when you go above the nucleus and cross the equator, and then divide the nucleus into two. So as you divide the nucleus, you can also make multiple divisions, and by this you can actually reduce the size of the nucleus and the extent of the sclerocorneal damage. Now, what is important to know is that in phacoemulsification, we are doing ultrasound damage inside the eye, by emulsifying such hard nucleuses. Whereas in SICS, we are adding a little bit of more sclerocorneal dissection to the surgery. I think this is the point of balance. And we need to understand that in SICS, because we are doing the in very hard nucleus, because we need a lot of energy in the eye to emulsify such cataracts. Probably if we want a very clear cornea the very first day and give a wonderful patient experience, we need to go and do the snare technique or maybe the SICS technique. In even the irrigating vectis, I showed you how we can have a huge incision and yet be watertight. So actually, we can cut the nucleus and reduce the cut size, but by snaring the nucleus, that's another surgery where you can see the snare technique, but I think for the want of time, I'll slip this surgery. Thank you for your attention. I'll be happy to take up any questions from your end. Thank you very much.
Thank you, sir, for your excellent videos on managing hard nucleus and also white nucleus. Now I invite Professor Mohammad Mizanur Rahman, our panelist, President ISMSICS Bangladesh chapter, to give your valuable opinion regarding this presentation, sir.
Sir, please unmute yourself.
Thank you, Dr. Mustaq. I think Dr. Debashish Bhattacharya, he had done a very difficult job, because for heart cataract, we always depend on SICS. Phaco is very difficult to manage this nucleus because it is very hard and it is very sticky and it is very large nucleus. For protection of corneal endothelium, we have to depend on these SICS. And Dr. Debashish has shown the different techniques of delivery of the nucleus, how we can remove the nucleus. I want to add few things. For easy removal of the nucleus, which part of your surgery is important? Whether it will depends on the tunnel making or it will depends on the floating of nucleus in the anterior chamber. Sometimes in my personal experience, I face some problem during delivery of nucleus, iridodialysis. Very large nucleus, there is no space in the anterior chamber. And when I introduce the irrigating vectis, sometimes it may interrupt the lower part of the iris, and after delivery removal of the nucleus, sometimes it may cause iridodialysis. This is one thing, how we can prevent it. Another thing is that if we use sodium hyaluronate, I think it will be helpful for the protection of the corneal endothelium. What is your opinion? And lastly, what is the best method of removal of the nucleus? What is your opinion for us? What is your suggestion for us? How to easily remove this hard nucleus? Thank you, Dr. Debashish.
Thank you, Professor Mizanur, and few valid points brought out. I think the first thing that viscoelastics, well, as such, we must understand that the nucleus is thick, but it was inside the eye. So from the posterior chamber or from the capsular envelope, we have brought it to the anterior chamber. So there is space in the eye. So we need not bother about viscoelastics, because SICS, if we are touching the nucleus, endothelium with the nucleus, I don't think we are doing a good job. So we shouldn't be touching the nucleus, endothelium with the nucleus. So I don't think the viscoelastic protection has got anything to do with skill hands. Yes, I mean, for trainee, they can give heavy viscoelastics, dispersive viscoelastics, in front and behind. Regarding the iododialysis, I think we try to give a mechanical direction to the nucleus um, and try to pull it up. We try to pull it up. So, and if our vectis goes behind or, at the level of the iris, when it crosses the pupil, then because the nucleus is sitting there and we are pulling it up, so we are actually giving traction on the iris and there will be an iridodialysis. But the essential idea of an irrigating vectis is to go just behind the nucleus, start the irrigation. The direction of the eye must be such that it should be towards us, that the incision must be towards us. And now we just press the posterior lip. As in Blumenthal technique, it will come and engage in the incision, and the incision must be very well crafted to accommodate the nucleus. It will engage in the incision and come out. So I haven't had this problem of iridodialysis. But yes, I mean, we do see cases of iridodialysis during this procedure, which has been rightly pointed out. And the third thing was sometimes, making a big rhexis, because it's a bag full of nucleus. The entire capsular bag is full with hard nucleus inside the eye. So if we don't make a big rhexis, then that nucleus will not prolapse out. Obviously, stretching the nucleus and prolapsing one pole with bimanually and then walking on the equator of the lens, or to simplify it, we can do the envelope technique, or we can actually, if the nucleus is not coming out, we should give multiple release. And that actually still preserves the capsular integrity, the bag integrity, but there are multiple releases, not one, but at least 6 to 8 releases, and the nucleus will then easily come out. So that is another problem. And in fact, because the zonules are weak, so we shouldn't be trying too much to prolapse the nucleus out of the bag forcefully, because these cases also are accompanied with weak zonules because they are elderly patients. So these are some points which I could add on.
Thank you very much. Thank you, Dr. Devashish.
Can I add one point to this?
Yes, sir.
Yes, sir.
Yes.
See what happened now, when you have got a nucleus of that big size and hard, you don't see the iris, where the iris lies. Most of the time when you are putting the vectis directly and going towards the 6 o'clock, there is a lot of chances that you can catch the iris. That is where the dialysis happens. So if you start from the side above the iris diaphragm, you keep your vectis position above the iris diaphragm from the side, and then take it to 6 o'clock, chances of catching the iris is less. That is one. And sufficiently you have to inject vectis to create a space between the lens and the iris. That is two. So the first point is that before one day you can give a IOPR SR. So many a time I've seen the iris prolapse happen. Suppose the borderline, I think 2 days before I had a case like that. I had on one eye. That time also there was little iris prolapse. I had managed it. But this time I thought there would be nothing. But again, before the operation, I measured the pressure. It was 22. I said there will be nothing. But again, there was a little iris prolapse. So I managed it. But if you give that and the eye becomes little low pressure, you operate, and I don't think these things will happen. And as Devashish shown it, the incision was so good. So that incision also contributes sometimes for this prolapse. If it is, and many a time the handling of the instrument is a very important point, because people roughly put it thinking that everything will come out and all this thing. With one moment of non-observation can create a mess. So I think we have to be very careful.
Yeah, I mean, the iris prolapse is mostly not, sometimes it may be if the patient is straining too much, but mostly when we see iris prolapses occurring, it is because of a badly constructed wound. The corneal valve, as Saucer has pointed out, that the corneal valve is not constructed properly. It is shallow or it's insufficient. So that is the iris will prolapse. And of course, I mean, one thing we must always keep in mind that the vectis is just to guide the nucleus into the tunnel, and we have to depress the posterior lip with the vectis. That's all. The nucleus should come out on its own. So the question of pulling out the nucleus, often, I mean, we do endothelial damage because when the nucleus gets stuck in the tunnel, if we have a small, the nucleus may get stuck in the internal incision. If our internal incision is small, and that time if we try to pull up or try to engage the nucleus, we are rubbing on the endothelium, then it might get stuck in the tunnel, and then because it is not coming out, we are trying to apply some force up. Then again, we are rubbing the nucleus part which is there in the anterior chamber will touch the endothelium, and we are going to damage the endothelium. And then again, if the external incision is small, the same thing can happen. It may get trapped in the incision, and the scleral pockets are inadequate. Again, the same things can happen. So all these four components, the internal incision, the corneal valve, the scleral pockets, the sclerocorneal dissection, and the external incision has to be perfectly aligned, and the rexis has to be perfectly aligned to the nucleus that we are dealing with. So.
Thank you very much, sir. Thank you, Dr. Devashish Bhattacharya, sir, the chief guest of our today's webinar. Dr. Devashish Bhattacharya, sir, has some pre-scheduled commitment, so I would like to request him to say a few words for this webinar as chief guest.
I mean, Bangladesh is my second home, so I mean, we are so happy. And in fact, I do remember that my last visit to Bangladesh, we actually formed the ISMSICS chapter, Bangladesh chapter. It's so nice to have a webinar. We could actually have, we are just waiting under the leadership of Professor Aba Hussain, who's the president of APAO, with such a pride for all of us, and Sharfuddin Saab, Professor Mizanur, Ashraful, Mili, Purabi. We saw everybody there, and it's so heartening to be amongst all of you. And of course, as with India, so also with Bangladesh, I have the PMMA counts in India from the Indian industry. 50% of the lenses are PMMA lenses. So let us understand that 50% of surgeries in India are done by PMMA, and so Bangladesh will be no different. So let us understand that we must perfect our skill sets to deliver the best where it actually matters. People who cannot undertake a revision surgery, or if we have scrambled somebody's endothelium, you cannot do a DMEC for them. So all these things we must be very careful that, and Dr. Baramani will be speaking that how well we can control astigmatisms and other things, and why not, I mean, these all patients of SICS, it's a way of doing cataract surgery. And if somebody masters it and he says, I don't like machine surgery, they might not will do it. So we can always have this option open. And thank you very much for being here today. It's, Durga Puja is a very big thing, but unfortunately, because of the COVID times, we have the huge pandals, we have the celebrations, but the people are very less because there are court orders that you cannot crowd the pandals. So the real essence of the pujas is not there, but we meet in families. So I have to go for a family outing. Please forgive me for the evening. Thank you very much, and wish you all the best for the remaining part of the webinar. Thank you.
Thank you, Dr. Devashish. Thank you. so much.
Okay, thank you. Thank you.
Okay, thank you, sir. Thank you, Devashish sir. We are really very much happy having you with us. Thank you, sir. Now, our next presenter, I like to invite Dr. Shams Mohammad Noman. He will talk on SICS in different situations. Dr. Shams Mohammad Noman.
Thank you so much, respected chairman, co-chairman, and respected panelists of this session. I'm really delighted to be here with you in the Bangladesh chapter of ISMSICS. And thank you everybody for inviting me in this session for the speaker. And I have no financial interest, and my topic is SICS in the different situations. I'm Dr. Shams Noman. Why manually small incision cataract surgery is very much important. We know it is a sutureless, self-sealing small incision, minimal astigmatism.
Your screen is not visible.
No one, please share your.
It's not visible.
No, please stop sharing and start sharing again.
Okay. Is it visible now?
Yes, now it's visible.
Yes. Make it full screen. Yes. Thank you.
Yes, visible.
Respected chairman, co-chairman, and panelist of this session, and I'm really delighted to be here with you as a speaker. ISMSICS Bangladesh chapter is a great organization, and today I want to present my topics. I don't have any financial interest. My topic is SICS in the different situation, and why manually small incision cataract surgery is important. Why still it is very much popular, because it is sutureless, self-sealing, small incision, we can make it a minimal astigmatism like phacoemulsification with modification of the incision with advantage of speed. Okay, mode of surgery, ease of surgery, low cost, low dependence on machine. It is an effective alternative to the phacoemulsification that is widely accepted and practiced in the developing world. This is one of my case, my very rigid people and herd cataract. This is, and after doing the minimum incision and CCC, even though it's small people, I am taking an advantage to do a tumbling of the nucleus. This is a very technique, very good technique. Actually, I am showing it a very slow motion because with if you do the tumbling in such case, a very small incision cataract surgery with a very small people, we can make it easy delivery. So this is tumbling. I used to do it in a very small people, and I'm getting a lot of advantages over this. So what is the advantage actually? The less manipulation, less epinucleus and cortex is remaining, and cortex removal is easy, and it's very much effective in the high volume surgery in case of, especially in the camp surgeries. But there is a problem. If it is a hard nucleus, a large nucleus, risk of genular tear that will be more in case of hard and large nucleus. So we have to avoid the tumbling in case of hard and large nucleus. And this is a case of lens-induced glaucoma after reduction of the inflammation and intraocular pressure. And I'm doing the manual small incision cataract surgery, and we have to take care of the liquid cortex, we can make a puncture and then we can remove the liquid cortex, then inflate the bag, and after doing the very careful CCC, we have to remove the nucleus, hard nucleus here, though it is a facolytic, but the nucleus is very hard. And in that case, we have to take care of the genule and you have to take care of the manipulation within the anterior chamber, because there might be a loose genule within it. And this is another case of facolytic glaucoma. After reduction of intraocular pressure and inflammation, I have after incision, I have make a puncture and I have removed all the liquid cortex, and I'm doing a CCC with a great precaution. It is better to do a small CCC and then you can extend a large one, because we don't have to touch the genular portion of the genular portion that can cause the more genular dialysis, and that will create a problem during operation. And very interesting, this is my observation. Sometimes in such cases, even after the cataract surgery, we can see some cortical materials, liquefied cortical materials behind the posterior capsule. And sometimes the beginners will used to run after that cortical materials behind the posterior capsule. And sometimes they used to do a posterior capsular wrench when they are trying to remove it. So this is my experience. Don't do hurry, and it will be absorbed later on. So this is the pre-op case, and the second one is immediate post-operative case where some liquefied cortex behind the posterior capsule, and it is gradually removing after 2 weeks. This is one of my study published in an international journal. The outcome of facolytic glaucoma. It's a very good result, even in the last follow-up after 3 months. And the good visual acuity is 618 to 618 is 62%, and the moderate, it is 23%. And it's a poor visual outcome. Sometimes if it is a very late case and where the endothelial decompensation, in that cases, the visual acuity is less than 660 in 13.95% cases. And the intraocular pressure has been controlled very nicely after the operation. So this is one of my case of preoperative facolytic glaucoma after SICS. This is the postoperative picture. And sometimes there is a debate that what is most important, phaco versus manual small incision cataract surgery. In the different studies, the Journal of Cataract and Refractive Surgery, they have also told the manual small incision cataract surgery, the outcome is good and it is safe and effective. And also in the Indian Journal of Ophthalmology, European Journal of Ophthalmology, different studies also suggested that both phacoemulsification and SICS achieves an excellent visual outcome in the hypermature cataract, but in the SICS has a low complication rate. SICS is significantly faster, less expensive, and less technology dependent than phacoemulsification. So SICS may be the more appropriate surgical procedures for the treatment of advanced cataract in the developing world. This is one of my case in a traumatic subluxated lens with a phacomorphic character. Here we have to do a very good CCC with a great precaution, because the Argentinian flag sign can be occurred. After doing the CCC, I am removing this nucleus very carefully, as it is a subluxated lens. The manipulation should be very minimum. And after removing of the lens, very carefully, I'm removing the cortex. And as it is a subluxation, I'm giving the capsular tension ring here before giving the intraocular lens. And this is very much important. Capsular tension, during introduction of capsular tension ring, we have to take care of the dialysis portion of the genule, because if the capsular tension ring just touches the dialysis portions of the genule, it can go through that dialysis into the vitreous. So we have to ensure that the CTR ring should be within the bag. So what are the contraindication of the CTR? Like complete continuous capsular access. If it is not complete continuous capsular access cannot be done. If there is any moderate posterior capsular rupture, if, in that cases, if you give the CTR ring, then the rupture will be more because there will be tensile due to excessive tension within the bag. And if there is an extensive generalized zonular weakness, and this is a case of very high intraocular pressure with cataract, moderate cataract. In that cases, I have to do the combined surgery, trabeculectomy and SICS. In that case, very good CCC is important. I am doing a tumbling here to take the advantage of less manipulation, and I'm removing the nucleus. Prior to this, I have to reduce the intraocular pressure because in that case, there might be a possibility of expulsive hemorrhage if you will do the operation in the high intraocular pressure. After doing the trabeculectomy, I am giving the suture. And I used to do a single suture trabeculectomy here, and the outcome is really very good. And the astigmatism is good. So what are the indications actually with high intraocular pressure? If it is not controlled with highest number of medication, we have to do the combined surgery where possibility of postoperative IOP spike and where the high risk of glaucoma with cataract. And this is another case of pseudo exfoliation with the rigid people. And after doing a very good scleral pocket, I did the tumbling and I removed the nucleus. But during tumbling, we have to think that if it is a very hard nucleus, we don't try the tumbling method. And I have done the combined surgery because it is a pseudo exfoliation syndrome with a advanced glaucoma. And so, in my experience, in the case of pseudo exfoliation glaucoma, early surgery is very much important. Combined surgery is very much important. The progression of glaucoma is more in the pseudo exfoliation glaucoma than the primary open angle glaucoma and normal tension glaucoma. And this is the advantage of single site surgery. It is a safe time. One wound is made. There is need for these surgeons to position should not be changed. But the disadvantage is there might be a more manipulation in case of beginners. So this is only the disadvantage. And this is one of my case when it's the subluxation of lens. And in that cases, I tried to do a tumbling method, but in that case, you can see the nucleus is trying to go behind. In that case, there is a pseudorant, and I did the vitrectomy. So I have shown this video that sometimes we should not try the tumbling in each and every cases. So we have to take precaution. We have to think again and again before doing the tumbling. This is a case of small incision cataract surgery. In case of intraocular foreign body, I have taken the opportunity to taking help from our vitreoretinal surgeon. I'm doing the small incision cataract surgery. After putting the intraocular lens, the vitreoretinal surgeon examined the posterior chamber with details with the help of the intraocular lens, and he got a intraocular foreign body iron particles because the patient was working in a sheep breaking area, and after doing the laser over the around the intraocular foreign body, then we have removed the foreign body, and after with the magnet we have finally removed the intraocular foreign body. So sometimes in case of young patient, there is no case of trauma or anything. So sometimes profession is very much important. Even patient doesn't know when the intraocular foreign body is entered because it is a very high force during this intraocular foreign body entry. That is a very high force entry. In some cases patient may not aware of this problem. So this is an accidental diagnosis. Sometimes we have to take care of the posterior segment evaluation in case of such type of unilateral complicated cataract. So this is my own study on manual small incision cataract surgery, and I just followed the WHO criteria, and according to WHO criteria, I have filled up all my protocols and everything, and I got the 90% of the cases in uncomplicated cases. I achieved a good visual acuity, and only less than 5% I got the poor visual acuity. And for this, I'm telling that it's small incision cataract surgery, if it is an uncomplicated case, if you know the perfect incision, if you do the good CCC, uh, it is really a very good surgery. It is compatible with the phaco surgery. So take home message, B scan. I have to give some special message to everybody. In case of hypermetric cataract, you have to do the B scan prior to the operation. Don't run after towards the cortex behind the posterior capsule in case of hypermetric cataract. Intraocular pressure reduction before cataract surgery in the glaucoma is very much important. No tumbling in the hard cataract, hard and large cataract. And you have to give the CTR if it is less than 180-degree general dialysis. If it is more than the 180-degree, it is better to give the MS segment. Thank you so much for your patient hearing. Thank you.
Thank you, Dr. Shams Mohammad Noman, for excellent delivery. Now I invite Professor Shokodara Shakur Mili to sum up the topics of Dr. Noman.
It was a wonderful presentation by Dr. Shamsuddin Noman. He has shown the cases of different situations like in peculitis glaucoma and hard cataract and hypermature cataract. So those are the difficult situations also. He has dealt those situations very nicely, and he has shown the tumbling method and other methods also. So in finally, I can say that he has managed all the cases very, very nicely. And because of his expertise as a glaucoma surgeon, he could manage the glaucoma cases very nicely. And he has shown how we can bring good outcome in difficult situations. And I like to thank ISMSICS Bangladesh chapter for arranging this webinar. And we have got presentations from Dr. Sahu and Dr. Devashish Bhattacharya sir. And those are the eye-openers. And he has, Dr. Sahu, with this I want to say that SICs is very much needed for reducing backlog of cataract in Bangladesh and in India also in other countries. In Bangladesh, we have a huge backlog. We can't do those with phaco emulsification because as in the presentation of Shams Mohammad Numan, we have seen we can do any cataract surgery in any situation with SICS. So our young ophthalmologists should be confident about that. We can do any surgery, any cataract surgery by SICS, but they have to be confident. To build up confidence, they have to do bulk surgeries, lot of surgeries, and they need to develop their expertise. And at this point, I think our Bangladesh chapter has some responsibility. We can develop a center for training of the SICS and the senior surgeons who are capable, like Shams Mohammad Noman and others. They can be the trainer and mentor for the young ophthalmologists. In that way, we can develop a good cataract surgeon, bulk of cataract surgeons, very expert in doing any situation in Bangladesh. And one thing finally I want to say in conclusion that doing PECO with a bad outcome is not our priority. We want to do good. If it is SICS and with better outcome, that is good. So we should go for our outcome is our more important aim. We have to look for the outcome. So I urge everyone to do good SICS surgery step by step to learn, and then to learn how to encounter difficult situations and bring better outcome, bring better vision to the patient. So thanks Norman for your wonderful presentation, and thanks ICMS SICS for inviting me to be the panelist. Thank you.
Thank you. Thank you, Professor Shaukatara Shakurmili, madam. You rightly said that every vision matters. Definitely every vision matters. Now we're moving to our next presenter. I would like to invite Dr. Muhammad Mustaq Ahmed, the General Secretary of ISMSICS Bangladesh chapter, for his talk. He will be talking about the traditional technique of nucleus delivery in SICS. Dr. Mustaq, please share your screen.
Thank you. Thank you, Dr. Ashraf. I just share my respected chairperson, chief guest, special guest, panelist, and audience. Uh, Welcome you all to my topic on traditional techniques of nucleus delivery in SICS.
Please make it full screen.
Two important steps in SICS to manage nucleus are nucleus follow-ups into anterior chamber and nucleus delivery through scleral tunnel. First step is nucleus follow-ups into the anterior chamber. First step in nucleus management in SICS is collapsing the nucleus from the capsular bag into the anterior chamber. This is challenging step for beginners. Proper capsulotomy is very important for easy nuclear polyps. Techniques are hydropolyps, Sinisky polyps, and bimanual polyps. In hydropolyps, hydrocannula is placed between the capsule and the cortex. Fluid is injected continuously. Slow and steady fluid injection raises hydrostatic pressure in the bag. One pole of the nucleus pops out of the bag. And the rest of the nucleus can then be gently wheeled out. Hydrocannula is placed between the capsule and fluid is injected continuously. And slow and steady fluid injection raises hydrostatic pressure within the bag. And once pole of the nucleus pops out of the bag, then rest of the nucleus can be gently wheeled out and whole of the nucleus came into the anterior chamber. Sinisky polyps, it is very important in case of when the adequate size of recapsulation is possible. The nucleus is pushed gently to the opposite side with the Sinisky. Once the equator of the hooked side is visible, a gentle lifting and rotatory movement is done. This movement is repeated like using a tire lever until the nucleus is fully prolapsed out of the bag. Sinisky is used to hook one end of the equator, then nucleus is gently pushed horizontally to the opposite side. Once the hooked side equator is visible, a gentle lifting and rotatory movement is done. And repeated lifting and rotating movements are done. And nucleus should be fully prolapsed out of the bag. Bimanual prolapse. It is important in case of beginners and also in case of hard nucleus. Two instruments are used, usually Sinisky with either plain spatula or hydrocannula. With cannula, the rhexis margin is retracted to one side. With Sinisky hook, the nucleus is pushed to the opposite side. Once the equator is visible, the cannula is taken below the nucleus and used as a fulcrum. Rest of the nucleus is then lifted and rotated out of the bag. It's a hard nucleus and pupil is not oil dilated. So in that case, either spatula or hydrocannula is used. With cannula, the rhexis margin is retracted to one side. With Sinisky hook, nucleus is pushed to the opposite side. And once the equator is visible, the cannula is taken beneath the nucleus and used as fulcrum. Rest of the nucleus is lifted and rotated out of the bag. Second step is nucleus delivery through the sclerocorneal tunnel. These are various techniques for nucleus delivery. Sclerocorneal tunnel size plays a crucial role in this step. The techniques are hydroexpression, that is Blumenthal technique with irrigating vectis, viscoexpression, Foucault-Pans technique, sandwich technique with Sinitsky hook or with viscocannula, Henning fish hook technique. Hydroexpression with irrigating vectis is unique. Basic principle: to elevate hydrostatic pressure in the anterior chamber, the main wound is opened by depressing lower margin by irrigating vectis. Nucleus comes out through the tunnel following the pressure gradient. Superior rectus viral suture should be pulled tight to fix the blow. Viscoelastic should be injected underneath the nucleus. Check the vectis. Superior rectus viral suture is held loosely in left hand. With concave side up, irrigating vectis is inserted gently below the nucleus and push the lower lip, engage the nucleus. Make sure the distal end of vectis is seen under the nucleus. Do not irrigate saline until the nucleus is engaged in the tunnel. 3 steps should happen in synchrony. Lower lip of the wound depressed. Number 2, superior rectus viral suture is pulled tight. And number 3, irrigation vectis. Another way of nucleus delivery is viscoexpression. Thorough hydrodelineation is done to minimize the nucleus size. Anterior chamber is filled with OVD. Superior rectus viral suture is tightened. The curved viscocannula is inserted under the nucleus. OVD is injected and the floor of the tunnel depressed with the cannula itself. Along with OVD, nucleus also comes out with the tunnel. First OVD is under the nucleus, push the posterior lip and nucleus came out automatically. So proper preoperative evaluation of cataract grade is very much important for proper nucleus prolapse and management. Customized incision and tunnel size should be maintained. Adequate size of capsulorhexis decrease complications like zonular tear. Ideal maneuver of instruments and nucleus causes less corneal complication. Perioperative decisions makes operation easy and causes less complications. Thank you for patience hearing.
Thank you, Dr. Mustaq Hussain. Thank you, Dr. Mustaq Ahmed, for nice presentation. That's the traditional way of nucleus delivery in the SICS. Now, I would like to invite Professor Muhammad Abdul Kader for sum up the talk.
Thank you very much. It is very good evening and Sharadiya Shubhacha to everybody. It is a good, excellent presentation, excellent videos and well demonstrated nucleus delivery by Dr. Mustaq Ahmed. I must congratulate him for his good presentation. It is very much needed to nucleus delivery. Few steps. First is well constructed tunnel, and second is capsulorhexis, proper size of capsulorhexis, and then hydrodissection and hydrodelineation to deliver the nucleus to the anterior prolapse to the anterior chamber, and ultimately expulsion of the nucleus from the anterior chamber to the exterior. So before going to expulsion of the interior nucleus, we must care about the corneal endothelium. Corneal endothelium is of prime importance. to the actual outcome of the cataract surgery, especially SICS. And another important thing is to take care about the iris. In case of heart cataract, a large nucleus, large volume of nucleus sometimes engage the iris during the nucleus delivery. So these are the prime importance in this uh, nucleus delivery during the SICS surgery. Thank you very much. Thank you for inviting me as a panelist. Thank you.
Thank you, Professor Mohammad Abdul Qadir, Secretary General, Ophthalmological Society of Bangladesh, for sharing your experiences. Now I'd like to invite Dr. Ashraful Haq Ridoy, Treasurer, ISM SICS Bangladesh chapter. He will talk on converting to SICS from FACO, when and why. Dr. Ashraful Haq Ridoy.
Is my screen visible?
No. Share your screen.
No, Ashraf, your share screen is not visible.
Yes, now it's visible.
Thank you very much.
Now visible.
Respected Chair, the President, respected guest, this ISMSICS Bangladesh chapter webinar, I must show my gratitude to all for giving me the opportunity to speak here. So my topic is the converting to SICS, when and why. Nowadays, the cataract surgery is not only the cataract surgery, this is the refractive surgery. We are calling this the cataract refractive surgery. And the main goal of this is the giving the best possible visual outcome for the patient. So there is a question, what to do, phaco or SICS? Both are cataract surgery. In my practice, I do my 98% cases of the phaco surgery, but I am not happy to consider myself only a phaco surgeon. It is the cataract surgery, because we need to keep in mind and we need to be open minded that we have to give the better visual outcome and the best possible visual outcome to the patient. Either it is by phaco or it is by SICS. So when we are doing phaco, we have to be in broad mind that anytime in any situation for the betterment of the patient, we need to convert it to SICS. So what's the goal of the cataract surgery? The proper IOL position, and during the surgery, no eye structural damage, and I want my patient's cornea in the first post-operative, the clear cornea. So during the surgery, during the cataract surgery, either it is SICS, either it is phaco, I have to keep these points in mind. So the factors for SICS, why I will choose SICS? There are some factors, the instrument factors, the what phaco machine I have. Suppose I have the traditional longitudinal movement jackhammer machine and the cataract is cataract nigra and the black cataract. Is it wise for me to go for phaco? That is one of the thinking point. I should go for SICS. And also the cataract grade, hard cataract, small pupil, complicated cataract. So before evaluating and before proceeding to the surgery, I need to think the planning, the what I will do phaco or SICS. And obviously the per-operative situations, the rexis extension, lack of capsular support or zonular damage situation. Can I continue for phaco? If there is any chance that I should not continue phaco for the benefit of the patient, I should convert to SICS. And obviously, to the skill of the surgeon, the phaco surgeon matters, that every surgeon need to understand and need to remind his or her skill at the time of surgery. So when and why I will choose SICS over phaco? So some preoperative decision, as I told earlier, and Professor Mealy also told, that every vision matters. Yes. So in my setting, I have to keep in mind what phaco machine I have, my patient's type of grade of the cataract, and obviously the patient came to me for the cataract surgery. What is the endothelial cell count of the patient? I do the cataract very nicely, and first POD, the cornea become hazy. it is not the surgery. So I have to keep this point in my mind, and also the surgeon's confidence matters here. So this is the hard cataract, black cataract. So I will not go for phaco in this cataract. I shall proceed to SICS of this cataract. So I have to go for the tunnel and deliver the full nucleus and put the lens. And obviously this patient will give the first POD better vision than the phaco. So I extract the lens. Look at the lens. This is the hard cataract nigra. And the perioperative situations. What are the perioperative situations I need to convert from phaco to SICS? The most common is the posterior capsular tear. When the posterior capsular tear occur, but I have the support of the capsular rim, vitreous in the anterior chamber, we do the vitrectomy and enlarge the incision. All the vitreous is removed and cut. Anterior chamber is clean, and we can go for IOL and complete the surgery. This case, this is one of the case, white intumescent cataract, high intralenticular pressure. When doing the rhexis, there is lots of splitting of the rhexis and extension. So the here extension occurs, and we did the cut, and again we have done the started the rhexis, and that rhexis also splitted. So what's happened now? The situation that should I continue for phaco or SICS? Keep in mind, this patient continuing the SICS will give the better visual outcome. So always what we do for the better visual outcome of the patient, so we converted it to SICS and complete the surgery. And first postoperative day, the patient vision was 6/9. That is the fibrosed capsule, and you see the zonular dialysis is there. And when we do the rhexis, we cannot do it by cystotome and the forceps. We need to cut the capsular margin, and we need to separate the fibrosed areas. So this, after completing this capsulorhexis, the grade of the nucleus, this is a very hard nucleus. So always, and there is the possibility to have the addition of the nucleus and the capsule. So it's better to convert it, not to continue with the phaco. It's better to convert it in SICS, deliver the nucleus, put the IOL. But question is, in every capsular rhexis split or capsule extension, do we need SICS? No. This case, multiple places it rhexis extended, but I have managed it and completed the phaco, and I have put the intraocular lens here, and intraocular lens is in the bag, and I have completed the surgery. So I always tell, every eye matters, and every situation need to give the individual attention. So after the rhexis, this is a hard cataract and a training video. This is the sculpting. Look at the energy, the machine energy, it exceeded over 65, 70. So this patient will not have the clear cornea first postoperatively. So immediately stop the phaco, convert to SICS, give the lens. This will give the better visual outcome of the patient. And next case also, we're starting the phaco, but in between the sculpting, the pupil is getting small, smaller and small. And now look at the pupil size. So what is the ideal thing? But I think there will be some zonular dialysis there. So convert, stop phaco, and convert to SICS and complete the surgery. This was the case, the surgeon started phaco, but there was huge zonular dialysis there, pupil becoming small, so I sit and convert it to SICS. There is vitreous in the anterior chamber, and we extract the nucleus with the big tunnel, manual small incision cataract surgery, and did the vitrectomy also. There is the manual vitrectomy, and we did with the vitrector, we did the vitrectomy, and then make the pupil in size and give the lens. Because if we proceed for phaco in this case, it would go to the retinal surgeon for next year surgery. So in every cases of the phaco surgery, we need to give the best possible surgical outcome. So a surgeon, before the proceeding for the surgery, need proper preoperative evaluations and the preoperative planning that should I go for phaco or should I go for SICS? What my patient will be benefited and leave behind the phaco. I am the phaco surgeon. I have to do phaco. No, leave this ego and think the best possible thinking for the patient. And keep in mind always a happy patient will give always smile to the happy surgeon. So thank you very much. Thank you for patient hearing.
Thank you, Dr. Ashraful Haq Ridoy, for excellent presentation and showed very good videos. Now, Professor Hosham Jaida, President ISMSICS Egypt chapter, to give you valuable opinion regarding these topics. Professor Hosham Jaida, please.
Thank you. Thank you, Dr. Mosaic. Thank you, Dr. Ashraf, Dr. Ava, and all my professors and colleagues for having me in this prestigious meeting. And you are giving me the opportunity to share with this great work from the son of the Bangladesh and the India too. As the president of the Egypt chapter of the ISMCIS, I have to congratulate Dr. Ashraf for the excellent presentation and the wise decision for the patient. And he was talking about the ego. Actually, we had the ego. We are not in need for more ego on the expense of our patients. Actually, we have done the old and difficult cases of the phacoemulsification, even the brown cataract and the cataract nigra. We have done it. But actually, after this long time of the experience of the hard times with these cases, the wise decision today to convert to the small incision cataract surgery. Actually, I have learned the small incision cataract surgery 10 years ago here in Egypt, and I was mastering this technique. Then I shifted to phacoemulsification. Nowadays, the past few years ago, I shifted my mind totally. I'm doing all the hard cases with the small incision cataract, even if the old situations are helping me to do phacoemulsification based on the experience of the post-operative results. I had a very clear cornea at the first morning with the small incision cataract, while with the phaco, even under cooling with the visco material or the visco substance, cooling the endothelium all the time, the old steps during the emulsification of this hard cataract and this stony cataract, I had almost the last corneal edema, which make my patient unsatisfied, which make my patient photosensitive and with no good vision at the first days after surgery. While with the small incision cataract, I took very short time, very less stress on your heart and your coronaries, and at the same time, my patient is totally satisfied. So no ego at all. I have to choose the more beneficial for the patient and the more beneficial at the end for me as a surgeon, because of the patient will ask you about the result, not about the technique. All patients may ask for the new technique, the sutureless technique, but the small incision cataract is still sutureless. No matter, no extra cap, no stitches, no high astigmatism. And I would like to ask Dr. Ashraf about the preferred distance of the scare tunnel from the limbs. I saw in your videos that you are somewhat close to the limbs. On my preference, I prefer to put it to at least 2 millimeters from the cornea, even 2.5 to lower the astigmatism. I had done 2.7 diopter astigmatism after the small incision cataract. When put my incision, the straight incision, 2.5 millimeters from the cornea, it's somewhat difficult manipulation, but with the least astigmatism postoperatively. What's your opinion and from your experience?
Thank you, sir. Thank you, sir. The thing is that for the scleral tunnel incision, I prefer at least 1.5 millimeter behind the limbus. So it's a 1.5 millimeter to 2 millimeter behind the limbus. That is the ideal site of the incision. And I prefer for the straight incision and the frown incision. Thank you.
Yeah, okay, thank you very much. And the second question about the delivery. Would you like to deliver by this just pressure to and expression, hydro expression or visco expression of the nucleus, or you prefer to deliver it by the sandwich technique? Which one is better in your opinion?
So basically the thing is that it depends on the grade of the cataract. So I learned from the from Sahu sir and the Boramani sir for breaking the nucleus and deliver it, but I usually like to deliver full of the nucleus. So it depends on the grade of the nucleus. So if it is the soft nucleus, you can go for the visco delivery also. But if it is the hard nucleus, you can. I always prefer for the vectis delivery.
Okay, but I think the expression of the nucleus with the big one, I think the nucleus will be stuck like the obstructed liver. So it will take some time and some manipulations, which may hurt the endothelium. So the sandwich technique may be suitable in such cases, right?
Yeah.
To get some force and to keep protecting your endothelium from hitting by the repeated delivery of this hard nucleus. Your presentation was great and your opinion was so wise. So I'm supporting this this attitude to shift the small incision cataract surgery when you don't have the proper machine, when you have the hard cataract, and also when you have a patient with a bad cornea, with a corneal comorbidity, to save the cornea for the coming years. Thank you very much, and thank you for having me in this great meeting.
Thank you, sir.
Thank you, Professor Hussam Jaida, for your valuable comments. Now I invite Dr. Purvi Rani Devnath. She will talk on SICS in difficult situations. Dr. Purvi Rani Devnath, please.
Madam, please unmute yourself.
Dr. Purvi, would you please remove that screen?
Yes. Good evening, everyone. Thank you all for giving me the opportunity to speak here. Respected chairperson, Professor Abha Madam, Chief Guest, Special Guest, and the learned panelist. Today I like to talk on small incision cataract surgery in difficult cases. Though, am I audible?
Yes, you are audible. Please continue.
Okay, thank you. Though phaco is the most modern technique in cataract surgery, still in our perspective, like financial ability, number of skilled manpower, and backlog of cataract patient, and the number of instrumental support, we need to select small incision cataract surgery. Difficult situation that we commonly face in our day-to-day surgery: small pupil, brown cataract, hypermature white cataract, subluxated cataract, and complicated cataract. During rhexis, nucleus prolapse, and cortex aspiration. We can overcome it by using cohesive viscoelastics, that is viscomydriasis, by stressing of pupil with Tusimsky hook or with the help of Irish hook or pupil expander. Stressing done with the help of Tusimsky hook 180-degree apart in opposite direction. This case of mature cataract with a small pupil, peritomy and cautery, making Whitfield cautery, and making a side port. Through this side port, I applied triple blue dye and introduced 4 Irish hook for expanding the pupil. Then rhexis made. After making rhexis, nucleus prolapse in the anterior chamber done, and extraction of nucleus done with the help of rhexis. Another complicated case is hard brown cataract. As the nucleus size is larger, so less molding of nucleus and more chance of endothelial damage. We can overcome it by making a large tunnel by adequate funnel shaped spiral pocket and triple blue dye to get better contrast and larger rhexis for easy nucleus prolapse. And we always use dispersive viscoelastics to protect the corneal endothelium. In this cataract, I made side port, and through the side port, I did the rhexis. After making tunnel, the spiral pocket, internal pocket is larger than the external side. And nucleus delivery done with the help of rhexis. In case of white hypermature cataract, the capsule is more fragile and visibility is difficult. The interlenticular pressure is high and more chance to capsulorhexis extension. By using triple blue dye for better contrast of the anterior capsule, and we will always use dispersive and cohesive viscoelastics to protect the endothelium as well as the flattening of anterior capsule. To make a large rhexis is a challenge. Different techniques like small puncture with aspiration of cortical matter, double rhexis, spiral rhexis are helpful for safe and appropriate size rhexis. In this case, hypermature cataract with anterior capsular fibrosis. Initial plan to do phaco, and I'm trying to do the rhexis, but due to anterior capsular fibrosis, I need to take the help of venous. As the continuous curvinal rhexis not possible, so I converted the phaco to SICS. After cautery, making large tunnel and using, we need to keep in mind in every step for using the dispersive viscoelastics, because there is more chance to endothelial damage. Subluxated cataract is another difficult entity. Zonular weakness complicates every step of surgery. A detailed examination is mandatory. To see the extent of zonular weakness, presence of vitreous in anterior chamber, fundus examination and B-scan in case of opaque media. By using high molecular weight viscoelastics, capsular tension rig should be kept ready. Capsular exit should be initiated in an area away from the dialysis. Avoidance of excessive fluctuation in anterior chamber by counter paracentesis and gentle hydrodissection before rotation of nucleus. This case, the hypermature cataract with weak zonule. After making tunnel, I'm trying to do exist away from the area of zonular weakness. As the interlenticular tension is so high, so I'm reducing the interlenticular pressure by aspirating the cortical matter, liquefied cortex. As the zonular weakness, so I'm trying to put the CTRA in the subluxated area. As the nucleus smaller in size, as the pupil is smaller in size, so I need to, I also put a capsular tension hook for supporting of anterior capsule and not to enlarging the size of zonular extension. Complicated cataract, very common due to uveitis. Recurrence and chronic inflammation make the surgery difficult. Small pupil because of posterior synechia formation and pupillary membrane. Increased chance of bleeding intraoperatively due to fragile new vessels. And pre and postoperative inflammation is more in case of uveitic cataract. So we need to use meticulous steroid before starting surgery. So preoperative control of inflammation possible with the use of steroid and synochialysis if synechia present and use of Irish hook if there is synechia and precise and gentle maneuver during surgery, good control of postoperative inflammation with judicious use of steroid. Proper preoperative evaluation is necessary to formulate better strategy. Possible resource should be kept ready before surgery. Thank you all and wishing you a happy Durga Puja to you all. Thank you.
Thank you, Dr. Purubirani Devnath, for your time-demanding presentation. Now, the panelists talk. I request Professor Hasan Shoy Sorowardi. Please, sir, share your experiences regarding these topics.
Sir, please unmute yourself.
Now you hear me?
Yes, sir.
Yes, sir.
Okay. I feel honored and privileged as you call me down over here. And I see I'm become astonished seeing all sorts of things that are doing it since 1975 when we are doing surgery, cataract surgery 50 a day. But nowadays I have seen all sorts of things in front of me. What you are doing is marvelous. Anyway, going this side, I should go to my organizing side. First in the list, the Professor Aba Hussain, this marvelous lady and ophthalmologist of our country is proud. We are proud of her. What in time, what should be done, she is doing it. she is not doing this surgery, but she is making the way, facilities for the surgeons to do it. So it's a great job for organization. I should thank her, and from wholeheartedly, I pray to God to for his long life so that she can continue. Next is our chief guest, Devashish Bhattacharya. Okay, should I call him the hero? Why? That guy I've seen, and I've been in Disha Hospital before, and I saw the Professor Mudassir and Professor Abba being there. Anyway, I saw their names, the board. What I learned that this Bhattacharya he's a hero. Why? He's a good, not only a good surgeon, so nice organization. He's the hero of the revolution. He's taking this ophthalmic surgery up and making the Disha hospital. It's so big and marvelous, and the infrastructure is so good. The three guy, the Shamur, is taking the educational network, while Vikas, the genius man, taking the ophthalmic, the optometric networks, and Devashish is doing the all leadership. So I thank him, and I'm really I'm really astonished that she is a very that the guy for ophthalmology, that should be we should be proud of her. And Amallu Shahu, he is the senior person come over here, not here in join us with webinar. So I thank him so much. Why? He give us some valuable things that machine is doing in FACO, but when you are doing it, it's small incision surgery. And another thing I appreciate is that the side port and the lens, the what I should say, the monoclonal bifocal lens is using. It is encouraging why, and it is encouraging why that she is giving us the information that in small little session you can have everything. You don't need the lens check. But in my eyes, Professor Mahmood Chaudhary do the lens check in both of my eyes in the cataract surgery. But I think what Almullo Shahu, that guy, everything can be done. We don't need the lens of the heavy machine. Everything can be done by hand. Next is J. Buran is the learned guy. I shouldn't talk much. Why? My knowledge is so big to them, considering them, that I shouldn't talk about that. I will decide the name now. The another person, Bangladesh, and he's also a hero of ophthalmology, that is Sharfuddin Ahmed. And he's our leader, not only a day, to what he is also doing, not doing himself, but he's making facilities to the others to do it. And this Ashraful Haq, that guy is Rida, I didn't know his name even. He is my favorite student. And what he was talking today, I become astonished that, and he become the president of Young Ophthalmologists. Okay. So I appraise it why organization is much better than what you are doing by yourself. Well, Mizanur Rahman, the president of this, he's not only president of this, he's president of glaucoma. So many things. That intelligent man, he will not talk much, but he will be doing everything. And Professor Abba knows it. So, and myself also knows it. So we'll put him everywhere. If you need to do something, put Mizan, he will do it. Sharfuddin also support me, and Sharfuddin also know about it very much. And Hussein Jiyada, I thank him to join us. And another guy is Abdul Kader. To me, he's an educationist. To me, he's an educationist. That guy is needful in the society of ophthalmology, I'm telling you. And not only the politician will decorate sorts of things. These sorts of people like Abdul Kader should be in the ophthalmological society too. Shaukat Aramili, okay, marvelous lady. I think she is going to follow Professor Abba, and might perhaps she will replace her. Okay, let us see. She can go to her. Okay, be trained by her. It is not impossible. Purumirani Devnath, my favorite lady today talking, okay. She is a leader of the ophthalmology, not of the doctors, and I've been there in BMA, all sorts of things. And not only his leader, what he was doing, all the difficult job he was doing, I was watching it. My goodness. She proves that SICS is necessary. These difficult things, if you do with the PACO, you are going to spoil the eye. So I appreciate what she was doing. And Shams Mohammed Noman, wonder boy. The wonder boy, I should say, I think he may be a friend of my son. Okay, I'm not a little boy. My son is also associate professor of Bangabandhu. So that's why I say he's a wonder boy. Why? She is all square, doing surgery, doing everything. Whatever he does, I like it. And Ashraf, I did not know your name even. She was sick with the COVID. I didn't understand it, as I know him only Hriday. His name is Hriday, but Ashrafullah, you are doing so much. Another guy I invented, that is Musaq Ahmed. I didn't know him before. The way he do the job, I saw his surgery today, step by step, like Mizanur Rahman. I like it, really marvelous. What he is doing, I like it, step by step, and he could be a teacher to the juniors. Which also I want to conclude is that praising against Professor Abha Sen, Debashish, and our Shafuddin and other leaders, please make facilities to the juniors so that the ophthalmology can go to the top. Thank you very much.
Thank you, Professor Hassan Sheikh Sarwardi, sir, for your comments. Now, our last talk, I would like to invite our special guest, Dr. Jagannath Boramani, sir. He is the Executive Chairman of ISMSICS. Sir, please share your talk.
Thank you. Can you see my screen?
Yes, sir. Screens are visible and you're audible.
Yeah. First of all, let me thank all the executives of Bangladesh chapter of ISMSICS for inviting me in this webinar. It's a very happy event to interact with all of you and the chairman of Egypt chapter of ISMSICS, Professor Hosam Jada. I'm going to speak on my own technique of endo expression of nucleus. There are various ways how you take out the nucleus. Some techniques are push techniques, wherein you push the nucleus out, like the AC maintainer technique. AC maintainer is connected to the IV bottle, BSS bottle at a height of 60 centimeters. So there is continuous hydropressure into the entry chamber, and this hydropressure helps in pushing out the nucleus. Even in the irrigated victis, you are continuously irrigating the entry chamber, and this pressure pushes out the nucleus. Visco expression also is a pushing technique. So there are multiple pushing techniques, but the technique which I am going to show is a slightly different technique. I have been doing this technique for almost last 7 to 8 years, but 2 years back, the terminology of endo expression of nucleus, it's a very apt term, and this term was given by our beloved late friend, son of Dr. Ranjit Dhaliwal, Dr. Kumar Vikram Singh Dhaliwal. He had launched this term to my technique. It is endo expression of nucleus. We are very unfortunate to lose him at a very young age. Now let me show some of my videos. Now I am doing the surgeries under topical anesthesia and the entry chamber maintainer. So many times you need not break the nucleus also, and you just bring the nucleus in the tunnel and leave everything. Because of the hydro expression, the nucleus slowly gets out. I call it as the auto delivery. This is the auto delivery of the nucleus. You need not break the nucleus also, and the pressure which is building up in the entry chamber pushes out the nucleus. But many times you have to take the nucleus out through a small tunnel. Now, especially I am doing the customization of the incisions. So many times I don't want to induce astigmatism. That time my tunnel size is hardly 4 millimeters or sometimes 4.5 millimeters, but then the nucleus is big. Because the nucleus is big, if the astigmatism is less, I don't take very big incision. I try to deliver through a small nucleus, small incision. So if you have to deliver through a small incision, you have to naturally break the nucleus into the entry chamber. But if you push big instruments into the antechamber for breaking the nucleus, there are chances that you damage the endothelium or you may rupture the posterior capsule. Now, because I am using the AC maintainer, the AC maintainer always pushes the nucleus out. There is a build-up in the antechamber, and you are forming the antechamber because of the AC maintainer. But now the nucleus comes and gets stuck into the anterior chamber. Now, always there is a side port on the right side. Generally, I do all the techniques, all the manipulations through the side port, except for the delivery of the nucleus and the implanting of the IOL. So when the nucleus gets stuck, generally I take a Sinskey hook in my right hand, and that Sinskey hook is passed through the side port. Now this hook tries to push the nucleus out. So because hydropressure is not very effective, this is a mechanical pressure built up by the Sinskey hook. So it really pushes out the nucleus. So either the nucleus comes out, it stretches the sclera, comes out in toto, or sometimes the nucleus gets fragmented into the scleral tunnel. So this is a fragmentation of the nucleus into the scleral tunnel, and the expression is because of the pressure built up by the Sinskey hook. So that is why it is called as the endo expression. So we are expressing the nucleus from inside out. Now the question is, because you are not passing any big instrument into the antechamber, the endothelium is safe. Secondly, whatever is the pressure pushing of the pressure, the nucleus is now rubbing the walls of the scleral tunnel, and the nucleus is not rubbing the endothelium. You can see that the antechamber is fully maintained and the nucleus is rubbing the walls of the scleral tunnel. So endothelium, you are safely away from the endothelium. Nucleus gets fragmented, it comes out. You can see here the incision size is showed by a red mark. The incision size is very small and the nuclear size is quite big compared to the size of the incision. So because of the AC maintainer, now the nucleus slowly gets trapped into the scleral tunnel. Even though the incision is almost U-shaped, this might be about 3.5 to 4 millimeters. The nucleus cannot come out, it gets trapped. The tunnel wall is quite broad because of the side ports. So the nucleus can come and get trapped here, but it cannot come out. So take the Sinskey hook in the right hand and gently push the nucleus out. It gets divided into the scleral tunnel. So the division is not into the antechamber, but into the scleral tunnel. So that way, this fragmentation is quite safe, and this way you can take out the nuclear fragment. If you ask me the question whether you have to use AC maintainer for this technique, it is not necessary. Even you can push, if you are used to putting viscoelastics into the antechamber, you can make the chamber fully formed with viscoelastics, trap the nucleus into the scleral tunnel, and take the Sinskey hook in the right hand through the side port, push the nucleus out, try to push the nucleus out. This, I don't know, this may be my last video. Yeah, now I have used a sheets glide. The nucleus is quite brown one, hard one, and big one. So it cannot come out through the incision. Here the incision is the temporal one. So with the Sinskey hook, gently you are pushing. So you are pressing against the wall of the scleral tunnel, not pressing against the endothelium. Sometimes the nucleus comes out totally by stretching the scleral tunnel, and sometimes it gets fragmented. Because hard nucleus can be hard for phaco. It is an ultrasound energy nucleus can be hard for that. But our Sinskey hook is a metal hook. So any nucleus can be divided with a metal hook. Like snare can divide any nucleus. Similarly, a metal hook can divide any type of nucleus. This again, you can see the incision again U-shaped here. My shape of the incision varies according to the pre-operative astigmatism. This is about 5 millimeters, but the incision is U-shaped because maybe I have to induce only 0.25, 0.3 astigmatism here. Sometimes I take very big and straight incision. There is no problem if the astigmatism is very high. But if the astigmatism low and low, and sometimes if there is no astigmatism, my incision is a perfect U-shaping. So expressing out the nucleus with a mechanical pressure from inside out, it called as the endo expression of the nucleus. Can I show one more video? I think this is the last one. Now see again here the incision is U-shaped. Now you can notice that I don't do the initial groove. I straightway start dissecting with the crescent. The advantage of doing this way is that post-operatively the wound looks very, you can see hardly 2 millimeters of the wound, and rest of the wound is not seen. That is the advantage. So if you are now very well versed with the tunnel making, you can straight away start dissecting with the crescent without making the initial groove. This is less than 5 mm incision. So nucleus is big compared to the size of the incision. Press the lower lip with the repositor so the nucleus gets stuck into the scleral tunnel. Support the posterior wall of the scleral tunnel with other instruments and gently push the nucleus out. So either it comes out totally or it gets fragmented into the scleral tunnel. So this is phaco-fragmentation into the scleral tunnel, and the expression of the nucleus is the endo-expression of the nucleus. Even if a small chip get fragmented, gently you can rotate out, and the remaining nucleus can slowly turn and come out. I think this incision must be about 3.5 mm. Now this is U-shaped incision. Here the cornea must be split. This is less than 4 millimeters. I don't want to induce any astigmatism. But in this case, the nucleus is again big and hard one. But still this can be delivered because our scleral wall is sufficiently wide inside. The tunnel is quite wide. It can trap the nucleus. The astigmatism depends only upon the cord length or the ends of the incision and the distance from the limbus. Whatever dissection you do in the sclera doesn't matter as far as the astigmatism is concerned. See, there is slight stretching of the nucleus, sclera, because sclera is elastic, cornea is not elastic, sclera can stretch a bit. And many times because of the AC maintainer, the second segment just jumps out the moment you pass the repositor. No, here I think it is just jumping out. Yes. So this is the diagrammatic representations. This is scleral tunnel. The nucleus is now come and it has got stuck into the tunnel. Because of the AC maintainer or maybe with your viscoelastics, the space is always there. The nucleus is not rubbing the endothelium, and the Sinski hook pushes the nucleus in the scleral tunnel. So you are safely away from the posterior capsule as well as the endothelium. So this is, I think, one of the best way of manipulating or fragmenting the nucleus, the endo expression of the nucleus. Thank you very much for patient hearing.
Thank you, Dr. Jagannath Buramani sir, for the excellent presentation. And now I would like to invite Professor Muhammad Dr. Sharfuddin Ahmed sir, the President of Ophthalmological Society of Bangladesh, the panelist of today's webinar, to sum up the talk.
Thank you very much, Professor Abha Madam, Amullo Shah, and Devashish Bhattacharya, and also Jagannath Buramani, along with other speakers and panelists of Bangladesh. I want to say that Jagannath Buramani, he has shown us the excellent technique, and it is within 2 millimeters to 5 millimeters U-shaped. Very nicely he expressed the lens in the tunnel, and this is the endo expression of the nucleus. Very good technique, and our young ophthalmologist as well as the resident, they can also take this training from this video also. And also I think in future, face to face or physically, the young ophthalmologist will go to India, or we will invite Amullo Shahu and Jagannath Buramani to our country, and they will also teach our residents directly, face to face, physically. That will be more effective. And
we'll be very glad.
Yeah, thank you very much. I want to know from you that during this expression, did you get any experience of iris tag with the nucleus and removal, or there is the iridodialysis? Number one. And number two, if we can take all these things with our only hydro, no visco, did you get any experience of endothelial decompensation? Another thing, that if we only use the visco without hydro, is it possible to remove this nucleus through this tunnel? I thank you very much, and I think that this type of webinar is very much necessary, and these recordings from all speakers, I think excellent, and this will be very much helpful for our new young ophthalmologists and residents who are coming up. And I think we want to give the vision to the patient, not the technique. Sometimes we heard that one of our surgeons told that if you want to go from your room, or if you want to enter into your house, why you will come through the window, come through the doors. And that's why PACO and SICS, there was the differences. Sometimes the people from the rural area, when they are becoming established, they don't want to focus themselves that he is from rural area, he is the urban area. But this SICS, Amulya Shahu, I thank you that you started with your thinking that you all know everything. You know VACO, you know SICS, but you have given the new idea that small incision cataract surgery is not the neglected thing. This is for the giving the good vision to those who have the complicated, who have the hard brown cataract, and also bulk surgery is needed in our country. You see, in Bangladesh, there are 8 lakh backlog in cataract, and every year 1.2 120 million people are becoming cataractous blind. So this backlog should be removed by this type of facilities, not only with the machine. So one thing I am very much happy that Amulya Shahu also told that SICS is not the small incision cataract surgery, it is the scleral incision cataract surgery. Very good thing you have told. So you have started 2 millimeter and also endo expression of the lens, U-shaped scleral tunnel. I think this will be very much beneficial in future, and people will be able to see clearly, and the visual outcome will be much more. Where there is complication, where there is the difficulties, we can easily change from PACO to SICS. It is not the thing that I cannot. I want to give the good vision to the people, better outcome to the patient. There should not be any ego. With these few words, I thank all the presenters and all the speakers and panelists who had joined this SHS International Society of Manual Small Incision Cataract Surgery webinar. I thank Professor Abha Hossain and Dr. Mizanur Rahman for inviting me and to be the part of this webinar today. Thank you very much.
Thank you, Professor Sharfuddin Ahmed, sir. We will get back to you. Dr. Boramani, sir, can you please give the answers?
Yeah.
Hello.
Yes.
Hello.
Yes, sir. You're audible.
Yeah. There are 3 points. First, he asked about the iridodialysis and iris tags. Iridodialysis is not common even with this technique. Iris tags, if you do only with AC maintainer without viscoelastic, it can happen. Now, many times I'm used to just press the posterior scleral wall with the repositor, but instead of repositor, if we use a sheet slide in every case, then the iris tag or iris problem is almost minimized, because sheet slide is a broad flat thing which will prevent the iris from coming. So you have to be a little careful. It will be more safe if you do with the viscoelastic instead of only AC maintainer, as far as the endoexpression is concerned. But generally, I am very much used to AC maintainer. I don't use viscoelastic. It is not that I am very adamant. Whenever required, I use viscoelastic also. But the advantage of finishing the surgery without using viscoelastics is that you can prevent all the task-like problems which can develop because of the viscoelastics. So that is the only advantage. But otherwise, viscoelastics create a very good amount of space, and especially for the beginner, it will make the surgery very safe. Secondly, I also give a warning to the beginner that just by seeing such videos, don't venture into such techniques. When you are learning a SICS, first you concentrate on a safe delivery of the nucleus, like Dr. Devashish showed. Hard cutride big nucleus have a very sufficiently big incision. That time you don't think, oh, already has got this much astigmatism, my incision will increase this much astigmatism. Don't think of that time, because just to prevent or negate the astigmatism, don't try to jeopardize the endothelium. So first learn a good technique, good manipulation of the surgeries. If you see my videos of customization of the incision, I customize the incision. My incision is right from, say, now in this video I've seen sub 3 millimeter or 3 millimeters also, but 3 millimeter in my opinion is not required. If you have got a good U-shaped incision with 4.5 millimeter, that will not induce any astigmatism, and your struggle is very much less. But at times I have to do cases wherein the pre-existing astigmatism is 3 diopter. So this 3 diopter also is neutralized with a very big incision, 7.5 millimeter and straight incision. And instead of 1.5 millimeter away from the limbus, you come like slightly closer to the limbus. So by your judgment and your technique, you come to know how much astigmatism you are going to neutralize. There are many cases wherein the astigmatism is 1.5 or 2 diopters. Patient wanted multifocal IOLs. I use multifocal IOL, but without using a toric multifocal. The astigmatism is neutralized only with the incision, and you can market it as a premium surgery because it is a premium surgery without a premium IOL. Then, so you can charge your surgical charges can be more in such cases.
So in this incision, you are using sometimes multifocal even, and also you are
Yes,
not
yes.
giving that. You are not only giving the PMMA, can give the foldable lenses and also monofocal or
Yeah, yeah.
multifocal. Thank you.
My PMMA consumption is extremely less. The reason being, even if I put a 7 millimeter incision, many times I use foldable because patient want premium lenses. हमको ये कंपनी का चाहिए, वो कंपनी का चाहिए, imported चाहिए. That's why. And practicing in New Bombay is almost like practicing in Bombay. So in private practice, most of patients are affording. So my consumption of the local brand is very less. But you can, that is the advantage of SICS. You can use PMMA lenses, you can use foldable lenses, and most of the times you can use foldable lenses without much folding. So whatever the damage is created because of the injector, that is also prevented. So injector is very hardly needed. You can just slightly fold with the forceps and you can push the nucleus. That is another major advantage. But I'm using a lot of premium lenses in SICS. And now I can proudly say that last 5 to 6 years, I am 100% SICS surgeon. Phaco machine is kept on one side. I use phaco machine only for once a blue moon vitrectomy, and maybe after 2 days on Dashara for puja, I'll use it. I'll do the puja.
Thank you very much, sir. Thank you for excellent talks. Now, the second part of the webinar, we would like to hear some comments from our respected guest. I would like to invite Dr. Amulya Sahu sir, our keynote speaker, for his comment of the webinar.
One thing what I have seen in Bangladesh, everybody is so bright and feels that subcontinent is full of brilliant people, very enthusiastic, very much keen to learn, keen to share their experiences. That is quite encouraging. I think we are going to be good ambassador for SICS throughout the world. And many of the people I've seen, there will be future teachers who will teach people in the Western countries. Now they are also opening the door now. I want shortly we should be having a world conference in USA also. So a lot of things are going to happen, and I'm seeing a lot of future for the SICS. And Professor Sarfuddin, I think he's a very encouraging man, and he is very positive. Somebody who is there with the power structure. So this kind of people like him will be a boon for our things. He can open many doors and take the SICS training to the ground root level. Every institution might be. We are now designing the policy for training. I think Bangladesh should also develop a training program, and we join together so that we can market that training program to the world. Because a lot of people will like to from abroad to come and learn. So we will give them a choice whether which place you want to go and how to learn and all these things. Get positioned. I saw that a lot of you have shared, particularly your Asraful, I think you have also shared a lot of good videos. A lot of people, women, I saw their presentations were excellent. And please start the research thing. All of you who are masters now must focus on research. Unless we do that, we cannot come. Earlier, we were not talking much about the SICS because they were broad. They were cutting like anything, doing that. That was nobody will be encouraged to practice that. But if you see my 2 millimeter, why should you not do? And you surgeons are doing 2.5, and they are extending also after that. So if because I am in a stable position in the sclera, if I can do a 2 millimeter, I do all toric lenses and all these sort of IPCL and all sort of things. The machine, let it be there. My new machine is still, as Brahmani told, I have got a new phaco machine that is just there. However, I'm enjoying my surgery. So there is no compulsion that I must use the phaco, as all of you have shown. the converting to SICS, and there should be no ego. So I have enjoyed, and I am very much encouraged that Bangladesh is full of talents, and we are making we have made open the bridge. Now let us see how we influence the world. Thank you so much, all of you.
Thank you, Dr. Amulya Sahu, sir, for your excellent comment. I am going to Dr. Boramani sir. Dr. Boramani sir is the special guest and the speaker of our this webinar. Sir, please make your comment.
Yeah, all the videos were excellent today. Speakers were very good. You're doing a lot of good work, and the videos were excellent. Second thing, it was very nice to interact with all the Bangladesh executives today. So we feel very happy, and I was just feeling that when we're discussing the training programs, when the Corona will end, so that you can come to our country, we can visit your country. One more thing I wanted to say that your attendance was very high in the last CCC 2019 conference. Dr. Debashis was a wonderful host, and the conference was organized in a very good way. Maybe that time some apprehensions, maybe their attendance from Bangladesh was a little over 100. But for our next CCC, which is going to be PGI Chandigarh, now you also know how our conferences are held. So I expect more attendance from Bangladesh for PGI Chandigarh. If you can come to Kolkata, you can definitely come to Chandigarh. So many new things SICS you will be witnessing, and I'm not sure whether I have to declare it now or not. Mostly robotic SI surgery is the new development which is taking place in India, and I think it will be completed within 4 to 5 months. And most probably in Chandigarh there will be first live demonstration of robotic SICS surgery.
Okay, fine.
Thank you.
Thank you.
Thank you, sir. Thank you for your excellent comment. Now I would like to invite Professor Muhammad Sharfuddin Ahmed, the special guest of the webinar and the panelist of the webinar, for his comment.
Thank you very much. First of all, I will thank Professor Abha Hussain, who has started this Bangladesh chapter of manual small incision cataract surgery, international society. So Professor Abha Hussain, Professor Mizanur Rahman, Dr. Ashraful Haq, and all others who has taken initiation for this webinar, which is very much helpful for all of us, not only the young, also for the ophthalmologists who are not practicing, they should. I will just say one thing, that everyone should know SICS and then he should go for FACO. Before doing FACO, if anyone doesn't know SICS, he should not handle with FACO emulsification, or he should not be allowed to handle the FACO machine. Number one. Number two, you see, astigmatism can be minimized with 2 millimeter. Smart SICS. Today, the new thing is in the world that smart SICS is just combating all the astigmatism, and 2 millimeter incision, and also you see the endo expression which they have told. A snare is being used for breakdown of the nucleus, and they are making it fragmented and then bringing it through the small incision area in the scleral tunnel. So I think everything is becoming latest and becoming smart, and I hope smart small incision cataract surgery will be helpful in future for all the visual outcome for the patients, and we will be able to combat the cataract backlog from the world, including Bangladesh. I hope Amulya Sahu, Jagannath Boramani, Debashis Bhattacharya, who are the pioneer of this this organization, I hope they will be always with us and they will cooperate. Ophthalmological Society of Bangladesh, all the ophthalmologists of Bangladesh, and also International Society for the Manual Small Incision Cataract Surgery chapter of Bangladesh. They will be always with us. I thank all the speakers, including Ashraful Haq, Purobirani Devnath, Mustaq Ahmed, Shams Muhammad Noman, all the speaker from Bangladesh. They have presented very nicely. And I think the keynote speaker, Amulya Sahu, Jagannath Boramani, who are now presenting with us, they will also appreciate that the speakers who have presented, and their surgeries, that is also international standard. I hope in future they will be also the ambassador to other countries, including Brazil or in China, where they are needed of. Our surgeon will go there and they will perform their SICS in those countries, and they will also help in the prevention of global blindness. I hope we will be able to overcome, we will be joyful, and we will succeed in all respects. Thank you very much for inviting me to this webinar. Thank you very much. And our guests who are still with us for long period, I thank Amulya Sahu and Jagannath Boramani that you have joined with us in this webinar. Thank you very much.
Thank you.
Thank you, sir.
Thank you, everyone. Yeah.
Yes, sir. Thank you, sir. Now the session for chairperson. Now I invite Professor Abha Hussain, Chairman, ISMSICS Bangladesh chapter, and President-elect APAO, to deliver your valuable speech on today's webinar. Madam, please.
Madam.
Unmute call, madam.
Madam, unmute.
Madam, unmute korte hobe.
I'm sorry. Amazing session. I would like to express my heartfelt thanks to Dr. Amulya Sahu, Dr. Jagannath Boramani, and our chief guest, Dr. Debashish Bhattacharya, as because it is the willing of them that make us to make this webinar, as because they want that Bangladesh chapter will organize a webinar. Thank you very much, as because that is why we have arranged. We are also discussed that we will do, but it is according to your wish. So you deserve a great thanks from Bangladesh chapter. I would like to say one thing, that it is such a platform where Dr. Debashish Bhattacharya spoke on SICS in supra-hard cataract. Dr. Amulya Sahu, keynote speaker, only 2 millimeter incision. No difference between phaco and SICS. And Dr. Boramani, endo expression of the nucleus. In that platform, in that stage, our Shams Mohammad Noman, Dr. Mostaq, Dr. Purabi, and Dr. Ashraf, same way they are presenting their paper. So this is the achievement, that they have that much courage, that they are that much, I'm only telling that they are the rising sun and also the brightest star of the sky, as because they are equally following you and they are equally doing as best as you are doing your surgery. They are also, Professor Shafuddin also telling like that, as because we know our surgeon, we know their capacity. So I'm very happy, I'm very glad today to say that not in India and Pakistan, this is limited, but this is out beyond that. This is in the SARC area, this is in the APO region, and this is worldwide nowadays. Every aspect of the door is open now for SICS. Yes, our patient,